Thank you. Thank you for the kind introduction, and thank you the organizers and Yale University for giving me this opportunity to share some thoughts. Right. So the topic that I have chosen for this talk is needle manipulation, because once we insert the needle, we also sometimes manipulate the needle, and many times we manipulate without understanding why we are manipulating. So I am going to talk about four different kinds of manipulation, and before I go to a short PPT, I will just demonstrate the types of manipulation. Now imagine this Play-Doh is the tissue that we want to enter, and this is, imagine the needle. This toothpick is the needle. So we once we enter, the manipulations can be pistoning. Once we insert the needle, usually the textbook will say that the kind of movement that we do with pistoning is using our muscles of the finger go forward and backward. That is a back and forth or pistoning kind of motion. Sometimes you can use the simple elbow or any other motion. Doesn't really matter whether you use your finger or the elbow, wrist, whole hand. So that is number one, pistoning. Pistoning promotes healing. I'll tell you how. The second manipulation is called as fishing. Again, you insert the needle, but as from the entry point, you change, keeping the entry point same, you change the direction of the needle inside the body. So this would be called as fishing. As you can see, there are multiple exit points from the same entry point. This fishing, this fishing is something that is very effective with trigger point. So my entry point remains same. As you can see, the exit point or the tissue reach using the same entry point changes. So first one was pistoning, second one is fishing, the third one is needle rotation. Once you insert the needle, you can rotate the needle along its longitudinal axis. So that would be called as needle rotation. And the final kind of uh, needle manipulation that I'm going to discuss in this session is called as periosteal pecking. Imagine this is the tissue and this particular plastic container is the bone. Periosteal pecking is when you reach for the through the tissue, through the soft tissue to the bone, and you do tap 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 on the bone. So that would be called as, of course, you don't pick it up fully, you keep the entry point intact and then you keep on tapping. So that would be called as periosteal pecking. Now with this four kinds of introduction of four types of needle manipulation, let me go to a small PowerPoint where I explain why they are done and how they help. Uh, Let me share my screen. Okay. So, right. Just a wordplay, fiddling with the needle, needle manipulation during dry needling. Now, I specify dry needling because the other use of filiform needle, solid needle in traditional Chinese medicine has some different kinds of needle manipulation according to the Chinese aesthetics. Sometimes they say the wagging of the tail of the dragon or moving of the head of the white tiger, something like that. But let us keep it simple and let us think of it from a physiotherapist's perspective, not from acupuncture, from dry needling. And then uh, we are going to discuss pistoning, fishing, needle rotation, and periosteal pecking. And let us pick the pistoning first. So while talking about pistoning, what is pistoning is, as you can see, there is a nice mechanical piston here, which has the back and forth motion. And similarly, when you do pistoning, we do with needle a back and forth motion after insertion, never coming out fully from the entry point. Usually a 10 millimeter, about 10 centimeter movement happens, and its purpose is primarily it promotes healing, and then it provides a delta stimulation, so it works in pain gate mechanism, reduces pain. How does it do it? To understand that, we must understand that below the skin, the intact tissue is homogeneous. The ECF is full of ion and the ions are distributed more or less homogeneously. So the positive ions and negative ions coexist peacefully. But when you have inserted the needle inside the tissue, what happens is you have created and you have taken out the needle, you have created a small well. Um, uh, the diameter of the usual needle is about 0.25 millimeters, so this hole may not be seen also. But you still know that there is a hole. Sometimes blood comes out, sometimes tissue fluid comes out, sometimes doesn't nothing comes out, but there is a gap. And as we know from our basic electrophysics, biophysics, that wherever there is a hole like this, or wherever there is an opening in the tissue, or wherever there is an opening in any area, on the surface, negative charges come and accumulate. So what it means is, wherever you have created a hole or opening, there is an ionic redistribution. So on the in the say depth of the well, you have the negative charges because they tend to come in the outer side. On the sides, you have positive charges. So in effect, this looks like a battery. That means in this area, you have a specific concentration of negative charges and specific concentration of positive charges. Now, this negative and positive potential difference keeps on giving some kind of signals. And this signal, a small battery, is propagated to the tissues that are nearby. And what are the tissues here? The tissues can be fibroblasts, the tissues can be macrophages, the tissues are lymphocytes, and other inflammatory cells. So they come rushing towards the area of this needle, that is area of injury that you have created, the injury that you have created. And they kind of fibroblasts lay down the collagen, macrophages take out the infection, and all the works of our immune system starts while once this battery is created. Now, good thing about this is you may have taken out the needle, but still the battery will be present, or this will be working based upon the size of the wound and based upon the area and the depth of the wound. This battery will remain for about 1 to 3 days. This particular injury potential, of course, I'm using this term injury potential loosely because the same term is also used in case of myocardial infarction, but you get the point. So, this now, how the needle manipulation helps. If you create this pistoning again and again and again, what you are doing in essence is you are widening the bore of that particular well, and you are probably increasing the depth of the well. So you are increasing the amount of tissue fluid that is present in this well, and you are increasing the amount of negative ions, that is probably electrons, present in this well. So you are giving a greater stimulation to produce healing. And if you want to if you want to promote healing, this is one of the way to promote healing via needling. Let us go to the next technique called as fishing. Now, as I said, fishing technique promotes trigger point deactivation. Now, first of all, what is a trigger point? Trigger point, as we know by definition, is a cluster of dysfunctional motor end plates. Although when we palpate, we tend to feel a single knotty point on the bone, KNOTTY, knotty point on the muscle, along with a band of, say, a taut band is the commonest term to describe a painful tender point or not on a taut band of muscle. So although you feel it like a single point, the electron microscope clearly show that it is not one single point, it is a cluster of dysfunctional motor end plate. As you can see in this picture, where it is a representation of the microscopic view view of the muscle fibers, these wide points here, 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 and here, the more red, darker white points are representative of dysfunctional motor inflets, which means that they do not exist in the same place. So what do you do uh, when you have multiple dysfunctional motor inflets? You insert the needle from one entry point. If you see here, you insert the needle from one entry point, and then you, in this picture it is going vertically, then you pull back like pistoning, and then you push it in again in a different direction to match or to touch another dysfunctional motor inflate. Then you pull back and you then change the direction to reach as many dysfunctional motor inflate as possible. So I will right. So coming back to, there is some intricacy where we had talked about the pistoning. It is clearly clear that it was simple, push back and pull in like this. But with the dysfunctional motor inflate, what you do is you pull it out. And how far do you pull out? You pull out till it becomes free on the surface of the skin, because you don't want to go, uh, because if you pull it halfway and not till the surface of the skin, then you bend. What is going to happen is the needle is going to bend, and as the needle bends, the needle, there is a chance of needle breaking. Theoretically good quality needles do not break, but the needle may bend, and as you insert, the needle will curve and needle will go back to its own previous pathway, the own groove. So you need to pull it out till the needle becomes loose on the surface. Change the direction only 5 to 10 degree, because we are staying on the same muscle, because we are trying to target the same trigger point. So beyond 5 to 10 degree doesn't really produces any difference. So after pulling back, you change the direction 5 to 10 degree, push it in. Okay, and as you push in, if you have hit the correct dysfunctional motor inflate, you will get a local twitch response. If you get a local twitch response, pull back. Now many textbooks say that once you have got a local twitch response, your work is done. But if the trigger point is bigger and the patient can tolerate that little bit of discomfort of local twitch response, which is a small contraction of the muscle, you may pull back and go and poke it again. So you may get one more twitch. If you are getting one more twitch, your effectiveness of the dry needling is probably going to increase. So pull back and push again in the same direction, like piston. Pull back, push again. Pull back and push again as many times as long as you are getting a twitch. Once the twitch is over, change the direction again 5 to 10 degree and repeat the same procedure. Now probably you are doing this for say 30 seconds to 1 minute. After that, you are free to pull out the needle and finish the wind up the needling session for that particular trigger point. So that was about fishing. Let me go back to the PowerPoint once again. Right. So the next needle manipulation is called as needle rotation. Usually, I see a lot of people, a lot of physiotherapists insert the needle while rotating. That may not be appropriate in all the time. The needle rotation at specific clear-cut indications, rotate the needle only when they satisfy the indications. Now, why would you rotate the needle? The needle, once rotated, can wind the myofascia or the fascial fibers around it. It's like, if I give you an example, you have a bowl of soupy noodle, the noodles being the myofascial fibers, and the soup being the extracellular matrix. You insert a fork and rotate around your fork. What will happen is the noodles will be accumulated, noodles will be tightened. So similarly, this is an example of the myofascia, where you see the black fibers are fascial fibers, including collagen, including reticulin, and then those kind of fibers. You can see the artery, arteriole, venule, capillary nerves. So all of them are together. Once you insert the needle and rotate, what will happen is you are going to tighten these fibers, and once you rotate in the opposite direction, you are going to loosen these fibers. So if this is actually an actual picture of the facial web where the facial fibers are present, it is almost like a piece of cloth. If you consider the facial fibers as a piece of cloth, and maybe these other structures, arteriole, venule, nerves, are embroideries on the piece of cloth, then once you insert the rotated needle, what is going to happen is you are going to tighten, rotate opposite, and you are going to loosen the facial fibers. Now, how they are going to help? If you see this is an uninjured facial fiber, and this is a scar tissue facial fiber. As you can see, the fibers here are pretty much aligned. If you see, all are aligned at the degree of 60 to 65. Now, in this scar tissue, number one is the direction of the alignment has changed, because the alignment direction or the collagen directions are depending upon also the functional stresses that the body gives. Second is, although this is pretty organized, in many of the scars where the scars do not get enough stimulation for the direction, the scars also are disorganized, goes in multiple directions, where rotating and unrotating opposite, so tightening, rotating and rotating in the opposite direction, clockwise and counterclockwise, will give the fascia kind of a stimulus to tighten and loosen. If I am allowed to give you an example, a metaphor, you have a tablecloth, and the tablecloth is clumsy. With insertion and rotation clockwise and counterclockwise, you can actually take up the tablecloth, you can give it a shake and keep it on the table, that will be spread more or less in a straight way. I will stop the share and I will show another kind of again model. So if you see this is a bit of cotton, and this cotton is the facial fibers, let us say, and this is the tissue overlying the facial fiber. The modeling clay is the tissue. Now, if I insert the needle and then if I rotate around this, you will get to see that around the needle, the facial fibers are rotated. It is getting tightened. And that is why it is important to understand when do you want to rotate the needle. You want to rotate the needle when you are working on a tissue which is having a chronic condition. You are working on a tissue which is having scar formation. You are working on a tissue where you want laying down on the collagen. And also, how much would you needle? How much will you rotate? You should not rotate like this. You had seen what happened, no? The whole of the tissue or whole of the collagen got rotated around the needle, because I have rotated only in one direction. So if I may put it again with my model. So again, let us say these are the facial fibers, and once you have inserted the needle, you rotate once clockwise, once anti-clockwise. You need more stimulation, clockwise and anti-clockwise. As many times you are rotating clockwise, you must rotate anti-clockwise. If you keep on rotating in one direction, then this thing is going to happen. The facial fibers are going to wind around, coil around your needle, and when you pull this back, you will see that the skin and the underlying tissues are going to be pulled back, and that is going to be exquisitely pretty painful for the patient, and also more than that, this is not going to serve any real purpose. So if you rotate clockwise, immediately rotate anti-clockwise. You are aiming for more stimulation. You must do it with, say, multiple times, repetition, rotation, clockwise, anti-clockwise, multiple times. I will share my presentation once again. The next and the last manipulation technique that I want to discuss is called as periosteal faking. In this, what do? We had, as we discussed, overlying the bone, the soft tissue you insert the needle onto, and after that you kind of poke it multiple times, tap 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 tap. Why do you do it? You do it on the emphasis on the junction between the bone, the periosteum, and the muscle or the tendon. This is pretty common, or this is more indicated in conditions like tennis elbow, or in conditions like say plantar fasciitis, and you would do it as a resort to promote healing. How? By creating an acute inflammation when there is a condition which is already having chronic inflammation. Creating an acute inflammation is not exclusive to periosteal pecking or dry needling for that matter. We have been using this with our deep transverse friction massage, with our CD access form of manipulation, or one of the factors that work wonderfully when you use shockwave therapy is also it creates an acute inflammation, because as we all know, acute inflammation produces or brings the chemical mediators of acute inflammation, which also are chemical mediators of healing. So acute inflammation promotes healing. Of course, there will be other side effects of acute inflammation. So when you're doing periosteal pecking, you must prepare the patient for a little bit of pain. And if it is on the thick skin, as in the plantar fascia or the medial plantar tubercle, where the proximal end of the plantar fascia is attached to, because it is thick skin, you may expect a drop of blood to come off. So you need to have extreme precautions, because that may produce infection and all other things. But this usually works pretty well to promote healing. Uh, Again, I will stop sharing and once again show how do we do it. If this is the underlying skin and this is the bone below that, inside this you insert the needle and you do tap 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 without going out of the contact of the soft tissue here itself. Now you would reach as far as you get the sharp resistance of the bone. Uh, that is how you do periosteal pecking. So these are the four techniques. Collectively, their functions are different. Pistoning promotes healing. Needle rotation brings the alignment of the collagen or fibroblast. Periosteal pecking promotes acute inflammation, and the what was the other one? Yeah, fishing. Fishing is directed towards dysfunctional motor end plates. Collectively, they also promote stimulation of A delta pathway, as we have discussed. So I would talk a little bit about how they regulate pain, and if you want a little more stimulus, just give me a moment as I share my screen again. So if we want a little more stimulus of A delta to promote analgesia, we may want to use any of this needle manipulation to promote analgesia as well. Just very brief, this is nothing but the Clayton's electrotherapy pain pathway. Just this is horizontal, and I have differentiated between the A delta and C pain, the fast pain and slow pain. As we know, the fast pain is like Duronto Express. There is no stop other than in the spinal cord, whereas slow pain is like a local train. It has got multiple stops in many places. So there are multiple mechanisms in place, which is one is the stop cell in the spinal cord gets stimulus, gets a collateral from A delta, and it kind of inhibits the substantia gelatinosa in the spinal cord itself to reduce pain. Now, there are other pathways as well. Nucleus reti magnus and can be stimulated via A delta stimulation, and then the nucleus paragigantocellularis of the medulla can be stimulated, and then your diffuse noxious inhibitory control reticularis dorsalis can be stimulated. So you at the end get an encephalinergic pathway. You get noradrenergic pathway, serotonergic pathway, as well as a cluster of other nucleus. All of them are dependent upon strong A delta stimulus that takes or that promotes analgesia. So all these are also as an adjunct of needle manipulation, not the primary purpose of needle manipulation, but as an adjunct they will help. However, whenever we are dealing with a needle, it is my responsibility to tell that needle can produce damage, and needle is known to produce around the chest wall. It is known to produce the pneumothorax, and also needle in other places can produce organ damage, nerve damage, and other problems. Uh, if necessary, or you should always do the cost benefit analysis before needling. You should always know what is the purpose of your needle. You should never needle thinking that the needle is like a magic potion that is going to create all your that is going to heal all your problems, but you must use needle very judiciously as a targeted form of therapy, and probably this kind of assessment system will help, where you can rule out all the contraindications, and a mnemonic kind of thing called the spider to help you with uh, kind of safe and effective needling. If you remind yourself before needling, then the research says that if you remind yourself the standard operative procedure before doing any activity or any intervention, the quality or the outcome of your procedure itself is much better. So with that, I would finish my finish my presentation or talk or whatever. I request you to throw me any question if you have.